the second of the Anthony Peake Consciousness Hour in Conversation, or INCONs. The design here is very much an informal conversation between individuals who are interested in a specific area of human experience. The particular thing we're going to be talking about today is extraordinary experiences in childhood and young adulthood, an area that really is quite neglected. And also a secondary area, which is the area of extraordinary experiences that are negative in their nature, in the sense that most reports and most academic research tends to focus in on the positives, positive near-death experiences, positive entity encounters, these type of things. But of course, there's a whole element and elements of these areas where they are less positive, and these are just as important. And these are the areas that we'll be discussing today as well. So what I'll do is very quick introduction who I am, and then I'll put you around the panel and they will explain who they are and their involvement. And then we'll get into a informal chat about matters mysterious and interesting. Okay, I'm Anthony Peake. I'm a writer. I'm based in West Sussex, originally from the Wirral in the northwest of England. I have written 11 books. I'm now embarking on my 12th book. My books have been translated into, I think, every major European language. Literally a few weeks ago, one of my books came out in Greek. I have lectured in the UK, Europe, Australia, North America. And my work basically is an analysis of what we mean to say we are conscious. What is the conscious experience within a seemingly dead universe, which is the things I'm interested in. Right, so that's a little bit about me. I'd now like to hand over to Dr. Natalie Tobert to explain about herself, and then we'll go around the table from there. So Natalie, the table is yours.
All right, thank you. I'm Natalie Tobert. I'm a medical anthropologist, and I've conducted research in Africa and in India, and with refugees and migrants in London. I've taught courses in the name of cultural diversity, which present different ways of understanding unusual experiences from other people's perspectives, so that doctors and healthcare providers can understand where their beliefs of the patients are coming from. And that I've been doing for the last 15, 20 years in different medical schools, hospitals, and universities. And I'm currently interested in anomalous experiences that seem to be negative and how they seem to be treated differently by researchers from those which are benevolent experiences, which are seen to be a gift for humanity. So I'm interested in exploring that. Thank you.
Donna.
Hi, Anthony. Thanks for inviting me along today. I'm Donna Thomas, and I'm a research fellow at the Centre for Children and Young People's Participation at the University of Central Lancashire. And we're a centre that does a lot of research with children and young people and look to developing innovative research methods and approaches that kind of challenge conventional research models and ideas about how research should be done, just to make sure really that marginalised and disenfranchised groups are included in social research. My main research interests, particularly at the moment, are children's, what we're calling at the moment, non-conventional experiences, but also exploring with children the nature of self. What does self mean? Because when we do social research with people, in fact, any kind of research, we meet people with a really big assumption about what it means to be a human being and what self means. So a lot of this work is about challenging that, which means bringing discussions around ontology into social science, which is something we don't really do a lot of. And that's the work that I'm involved in at the moment.
Thank you very much, Dr. Thomas. And Ed Gilchrist, can you tell us a little about yourself, Ed?
Sure. I'm Ed Gilchrist. I'm neither a doctor nor a current physicist or examiner in explorer in spiritual matters. I'm just a father of an individual who was special. My background is I did engineering at Cambridge, and And so, as Tony was saying just a few minutes before the show started, I'm probably seen as someone who is extremely left-brained, so very conscious of data and evidence, factual things. But I pointed out that I've been a bit of a convert since I became the father of my son Mark, who is now 36.
Wow.
He very briefly, the background is that Mark behaved all through his life as though he has autism. But that's a subject of diagnosis, and that can be challenged. He had epilepsy, serious epilepsy, and what was termed schizophrenia by a doctor, which we can discuss in a few minutes in the show if that topic comes up. But I think it's some of his experiences and the things that we've observed about him that may be of interest to the people watching and to the people in the show here. That's me. I'm Ed.
Okay, and this on that opportunity, I know, Ed, that you can only spare another 25 minutes with us because you have other things to do. So I think that you should take the opportunity now. Ed and I have worked together now for around about 15 years. We've known each other an awful long time. And when I lived on Wirral, Ed and I used to meet regularly, and Ed used to always describe the latest things that were happening in Mark's life. Now, I know that Ed has kept an extensive journal of the issues involving Mark, and the experiences that Ed has witnessed and other people have witnessed with Mark are really quite extraordinary, and suggest to me that individuals who experience temporal lobe epilepsy, individuals who experience schizophrenia and autism, their doors of perception are open broader and wider. It's as if their perceptual field is impinging upon a reality that is denied us neurotypicals. But it doesn't necessarily mean that reality isn't real, particularly if you have circumstances whereby the circumstances and what the person describes are then subsequently proved to be true. And I know there are various examples that Ed can share with us now about Mark and about his experiences. So, Ed, if you can just for 10, 15 minutes, the chair is yours to go through what you've witnessed and what you've seen.
Being thrown in the deep end is an interesting start for me on this show. Where should we start? I think what I should do is quickly describe Mark's life. He was born with a trauma. His cord was tied in a knot, so he was short of oxygen in the last few minutes prior to birth. And he was born very blue. He didn't cry for a few seconds, but he did. And they sent him home with us because he had all his fingers and toes, and because he was crying. The fact that he didn't stop crying for 2 years was lost on the medical people. Cried and cried and cried. It was almost like watching an adult in a baby's body. A very frustrated spirit that wanted to get out of this body that was encumbering him, that was stopping him from doing the things he felt he should be able to do. He wanted to climb when he was 3 months old, and he couldn't. So a lot of the things were frustration for him. So we didn't know what was the matter really, and it took a long while to persuade medical health people to pay any attention. He went to special school because he was finding it hard to listen and pay attention to things. And he was diagnosed with a learning slowness, a disability, by the health people, by the education people before he was 10. And then throughout his teens, he went with no further diagnosis. He was 17 when he was diagnosed with autism. Almost by accident, he came across someone with us at yet another neurological consultation with a specialist. And this person spotted him and said, "Is he autistic?" And we said, "Well, you tell us." So they did after some time. And what they said was really that they pointed out symptoms. And I think this discussion should really look more at what we see, the evidence we see, rather than the names and the labels we place on things. because those names and labels can be quite misleading. So he was labelled with autism and a number of autistic branches of autism, like Asperger's syndrome and childhood autism, and so on and so forth. And what did that do? That didn't do much to help him. Didn't do much to help us, except we did get some specific supports which we hadn't had before. And we were no longer stigmatized as parents who didn't know how to look after a child, which was good. And so we had noticed all the way through his teens, particularly, but in his earlier life, that he seemed to be able to read minds. It sounds a bit crazy, and I was always trying to explain to my wife that we had to be careful about how we interpret what we think we're saying. But he would do things like he would run down the stairs from his room if I was touching one of his objects or moving an object of his, and he would say, "Why are you doing that?" Like he'd be occupied upstairs, and then suddenly he'd come downstairs and say, "Why are you touching this?" And I'd wonder, how did he know this? And it was like he was connected to us or connected to his things in some way. We weren't really sure. We're not even sure now. And so this frustration in him, this anxiety in him, this sensitivity in him continued through his school years. And he was bullied as a consequence of him being different. And the bullying lasts with him to this day, and he's now 36. And that's really a post-traumatic stress disorder that he suffers now. He had a couple of major tonic-clonic seizures when he was 18. One after the other, a month apart, never had any seizures that we knew of before then. As it turns out now, we think that they were caused by the stress of his life. Here he was believing that no one was listening to him when he was listening to everyone else in their minds. We weren't listening to him anymore. I should say anymore, because I think when he was a baby, he probably thought that we were listening to him because his needs were very simple to observe. Change my nappy, we did it. Feed me, we did it. But when his needs become more complicated and he's thinking of them and we're not listening to them, then he begins to feel that, we're ignoring him, we're no longer in love, no longer loving him. And so that's my take on how he changed into being someone who was much more frustrated and anxious as he grew older, and quite apart from the rest of society. When he had his seizures, doctors had a look and they quickly diagnosed epilepsy. I think they were too quick. Certainly with the treatments, they fed him some major tablets. I'm not recommending that other people will have the same experiences with someone with epilepsy. So this is our story. This is what happened to him. And he was fed with some major tablets to control the epilepsy. That they did control the epilepsy for about 18 months. He didn't have another seizure, but he quickly became psychotic. And so all his anxieties and frustrations suddenly started to spill out into other things. Talking to things that we weren't aware of, getting really angry, getting aggressive. He used to play football and he would attack other footballers on the pitch within a few months of starting this medication. And he had to stop doing that. He would cry constantly on his bedside at night, wanting to know why this was happening to him. That was quite traumatic for us to watch that night after night after night. And what we believe was happening was that, and this is maybe an interesting observation for the two of you, Natalie and Donna. The medication appeared to make whatever connections he had to another world when he was younger, much more powerful, much more strong, much more connected, and we even, we did strange things, like we called an exorcist. It got so serious, and we were very frightened by what was happening. Things would move in the house, and he would claim no responsibility, and that didn't happen much, thankfully. That would have really freaked me out if it happened a lot. Sorry, my head's just going back over these things is quite difficult. My wife couldn't cope with it then, and she can't cope with it today. We can't talk about these things today because they were so horrific. And when I first met Tony, Mark was in the early stages of this, and we talked about it. We had a sorry, I was going to say the medication we thought was causing the problem, the exaggerated problem with him, and our doctors were not really good at listening to that. At about the same time, I started to keep a journal. That journal is over 1 million words long now. Every day of his life from 2005 was documented. And being an engineer and a bit of a nerd, I tabulated it and put some real data around it. So I gave it scores on a number of parameters that I then recorded each day, showing things like how he was behaving versus what was changing in his life, medication, environment, and so on and so forth. And that paid off in the end. But he was sent away from us because he became so disturbed that he was diagnosed with schizophrenia. He was then given schizophrenic antipsychotic drugs. So he was mixing the two drugs together, the anticonvulsants, the antipsychotics, and he got worse and worse and worse. His seizures increased enormously. He was having major seizures, like 6 to 7, 8 minute long shake seizures twice a month. And in between, you would see him shake it off a little bit, and then he would go back into the psychotic state, and then the seizure would off, and so on and so forth. And during in the aura either side of these seizures, in the few days either side of these seizures, you would see the biggest activity. So in terms of what we would thought was spiritual activity going on, a connection with the demonic world in some way. And also some of the strange phenomena that I've talked to Tony about. I'll describe one of them very quickly to you now. We had a friend who was a psychotherapist, and Mark would spend an hour or two with him every couple of weeks. And one of these days, we dropped him off at this man's house, and my wife and I went to have a cup of coffee in a local cafe nearby. And we were listening to the music that's piped through the cafe, and one of the songs came up, and my wife and I, being from the 60s, really, if you like, were very into challenging each other about which songs we know, which songs we don't know, and who wrote this and who sang that, and so on. So we were doing a bit of that, and one of them came up and said, "Who's that then?" She says, "Oh, that's Dave. That's Jimmy Ruffin. What Becomes the Broken Hearted," I think it was. So Jimmy Ruffin. And we say, "Oh yeah, that's Jimmy Ruffin." So off we go, and we finish our coffee, go back and pick him up, and we go into the house to get a debrief with this man, whose name is also Tony. And was settled with him. And as soon as we walked in, we met them in the kitchen, and Tony's just about to start talking about what had happened and how he'd been. And Mark says, "Don't forget to tell them about Jimmy Ruffin." And Tony looks at him and says, "What do you mean, Mark?" And he says, "Don't forget to tell them about Jimmy Ruffin." And we looked at each other, and I said, "Have you not been talking about it?" And he says, "No." And I told him the story, and we looked at Mark and says, "Where did that come from, Mark?" And of course, Mark was unable to tell us. So that's just a small story of the kind of thing he would do. Now, we had a witness for that particular one, and Mark was not the kind of person who would tell us things about music. Although from that day, he would sing songs that we didn't think he knew, which is an interesting thing. So he would hear songs on the radio in the car, and he'd be singing all the words, and I would hardly know them. And he'd be singing the words, not behind the words, but ahead of the words. And so he was very good at doing some things that we found fascinating. But, and this is where I'll probably stop and let you speak, ask questions, or maybe talk about something else. When we presented evidence to the doctors, the neurologists particularly, that linked the increasing medication, which they did over many years, to his seizure cycle and his behavior, we were able to demonstrate pretty scientifically, because I had daily evidence, empirical evidence for years, which I presented on a graph to the doctor and said, "Your medication's making him worse. He's having more seizures with your medication. He's having worse behavior with your medication." And after 12 weeks of special treatment that they gave him, he came off the medication. Well, he was put on a downward cycle. And that was 3 years ago, 4 or 5 years ago, when he stopped taking, or he reduced the medication. And 2 years ago, 2.5 years ago, he'd stopped completely. He hasn't had a seizure for 3 years, and he was having big ones. So no seizure medication anymore, no more seizures, but also, and much more important for this talk, no more psychotic connection. Okay. He does have post-traumatic stress from the bullying at school, and he does talk at them sometimes. And we see that as anger and anxiety and frustration and PTSD, really. He called it mental stress disorder, which I think is a far better description of what was going on than anyone has got in a book. It tends not to label him as having one particular brand of a problem in his head. Mental stress disorder is a disorder that comes from anything that stresses him mentally. So yeah, he has no seizures now, but he has little or no connection to the spirit world anymore. He doesn't do any predictions. He doesn't read minds, doesn't do any of that anymore. So there's an interesting twist, I think, on our belief that people have this skill, if you like, this gift. But his was exaggerated by the drugs, much more exaggerated. And now that he's off that, he doesn't do it anymore.
It's absolutely fascinating, isn't it, Ed? Because one of the things when you're talking there, I was reminded, and maybe the ladies could correct me on this, but there was a guy called Markolo, I think, who came up with autism, and I think it's called the loud world syndrome, where senses are much higher with somebody with autism, and the noise levels and the colours and the sights and the sounds and everything really drive them almost into a psychotic behaviour, which is similar to what's happened with people who experience schizophrenia. So I'm aware of time. Either of the doctors here would like to comment or ask Ed a question.
Can I make a comment? Because I'm so aware that the psychiatrist that I met in India always regarded any mental health situation as temporary. It was an event. It wasn't a condition for life. And also he recognized that there was a continuum between hypersensitivity, clairvoyance, and psychosis. And sometimes he felt he had to medicate someone if they were becoming oversensitive, where they couldn't control the data coming in. But then he would reduce the data. But that was the situation in India, where there was this assumption it was a condition, it was an event. It wasn't a condition for life. And I'm so sorry that you haven't been able to talk to a psychiatrist like that, but perhaps I can put you into email contact with him so that it would make you feel reassured that there's other ways of looking about this. I wrote this up in the book called Spiritual Psychiatries, based in India. So you might be interested in that.
I will be, yeah. Thank you for that.
It reminds me as well, Ed, of a case study that's come from some of my research with a young person who, at the age of 5, she was voice hearing, but these voices were really helpful. So, you know, if she was at school and she had an issue or a problem, she would hear voices where she described them as very helpful. And then I think about a year later, she was diagnosed as having epilepsy, interestingly, after she'd had a seizure. And then she was put onto medication. And then things went pretty much downhill from there. So her experiences changed, maybe in a more negative way. And this particular young person, she eventually ended up in hospital, so hospitalized. But I mean, the good news is she also had a transformational experience in hospital and has continued to self-heal ever since that, really. So off the medications. But I just wonder if it is something to do with a particular medication as well, because, you know, both of these cases, it could be similar types of medication. So there could be something in that.
I think the medication, we have to be very careful about medication. We have to observe it very closely as people take medications, and watch for changes in behaviour. Unfortunately, the society doesn't do that very well. Me being what I am, I just did it for years, and that's what rescued our son from that living hell. You know, but unfortunately, his life now has been, his best years have gone, and he's 36 now, and all that over the last 15 years or so, which should have been his best years, have been the most painful years. So it's very hard for the family now to live with that, the consequences of what happened.
Yeah, I think one of the major problems here, well, it's not the problem, it's an issue of context, and it's an issue of interpretation as to what happens when drugs are used to take off the edges of what somebody would consider to be unusual or aberrant behaviors here. Because if we take the argument, as Aldous Huxley and C.D. Broad argued, that the brain effectively is an attenuator, and the brain's process is to actually take out the broader areas of the informational field. The issues then is when we take substances that are not natural within the brain, what it does is it probably causes problems with the balance of the brain, and in which case it opens up other areas of perception that we wouldn't necessarily understand because the brain doesn't allow us to access those. And you just wonder with people like with Mark, you know, that suddenly the floodgates are open and everything is just flowing in some peculiar way. You know, it's which is intriguing because you know, for many years.
Excuse me.
Okay.
Keep going.
Okay, because could you actually, it's a wonderful opportunity now, Donna, to tell us a little bit about your work and what you're doing in this area, because I know very little about it. I know Natalie doesn't, but it would be really interesting to know more.
So I started a pilot study in 2019. It was a very small study, a pilot study, because it wanted to. It's really walking into the unknown a little bit. So the main idea was to explore, like I said before, what self means, instead of us going in as researchers and assuming what it means to be human. But of course, when we talk about self, we're talking about experience as well. So part of that was, and what are the experiences that you have? How do you experience the world? And we kind of advertised for children just purely from, have you had any, unusual experiences, and are you interested in talking about what self means to you? And what was really interesting is that we had a nice range of children and young people. So we had children and young people who had medical conditions such as narcolepsy, epilepsy, children and young people who had been diagnosed with mental health conditions. And I'm going like this because I don't like labels like everyone else. It makes me go like a little bit. And then, children and young people with neither. And we conducted really deep and slow interviews, using participatory research methods and using a range of creative and innovative methods that could allow children and young people to engage in this in meaningful ways. Because, if we have an experience that falls outside our ideas of personhood, we start to lose the capacity and language to even talk about our experiences and represent them with words. I mean, if you think about people who have NDEs, for example, and sometimes they can't even explain what they've experienced because we don't have words in our vocabs to talk about some of those experiences. And it was a very similar thing. So we used methods, such as drawing and art and movement and play. And these are methods that we would use anyway in our work, because we work a lot with children with disabilities, physical disabilities, and what people refer to as hidden disabilities as well. So it's about drawing on that expertise and looking at, well, how can we really explore with children and young people these experiences? But what was really interesting, and that's what really impressed me with you as well, Ed, because it's quite unusual to find a parent really that has that extended view of reality, to, the way you said, the spiritual experiences. Because what the study really began to show was children and young people, the distress from some of these, I mean, some of them were wonderful and some of them were a little bit distressing, but it felt like the distress wasn't really coming from the experience, but it was coming more from how adults responded to their experiences. And so this became quite interesting. So an example of that would be one young person didn't have any pre-existing conditions. She just joined the study because she was having a spectrum of kind of anomalous, non-conventional experiences. And so she joined the study, and she was talking about one particular incident where she had a tendency to see beings, and she'd got quite used to it, so it'd become a bit of a norm for her, and it didn't really shake her. But she decided to tell her parent, and the first response was, "Oh, you've got schizophrenia." So it's kind of a conditioned, knee-jerk response that felt like that's where the distress started to come more than the actual phenomena. And it feels like children have more of a natural propensity for these kinds of expanded experiences. So that was kind of the biggest thing. And children and young people, regardless of whether they had a condition or not, were sharing, a huge spectrum of experiences. The biggest one was out-of-body experiences, which was quite interesting, and lucid dreaming, which was very common. And interestingly, again, the lucid dreaming, it seemed to increase in the lockdown. And I know there's been a few people talking about this. I know you're smiling, so you've probably heard something about this. So, yeah. So the pilot's finished now, and there's lots of stuff. I probably won't have time to talk about everything that came out of that. Children also demonstrated that they were shifting between these different senses of self, which was quite interesting. So they started from this conceptual I, this conceptual sense of self that came through a narrative, it was very linear. And then when they started to talk about or draw or try to convey any kind of more transpersonal experiences, the sense of self kind of shifted again slightly. So the stories became very kind of non-linear spatial, that they started to lose their language. So they had to start drawing or making shapes to try and talk about some of these experiences. Some of them, there were a lot of geometric shapes as well, and tunnels to represent senses of self or particular experiences or particular dreams and things like this as well. So some really, really interesting stuff that came out of that. But we also introduced a technique called take a selfie. And what we did, we pulled from some of the kind of Eastern philosophies that talk about self-inquiry, and we pulled them from young people's kind of pop culture stuff around taking a selfie, and we combined that. And we did a few activities with just testing this method with children. So the idea is your attention, it's a camera and you can zoom in and out. And we got them practicing on kind of outside objects, and then turning that round and going to the inside objects, which might be a thought or a story, or a feeling, and then asking, but who's that one who's looking at them? And that was incredibly interesting. And that brought them to, together, we all called it kind of a knowing eye, because there were no words for that really. And it was just kind of, I don't know, but I just know. And that was it at that level. So the study it looked at a lot more than, just the non-conventional experiences. But the next steps for that is that we want to make that broader. We want to go across the country a bit more, but we also want to take it internationally to kind of work with children from Indigenous communities, because there's something very socio-cultural here. And there's something about how children and young people are responded to and supported and held and understood with these experiences, whether they're positive or whether they're negative. They're still kind of the same phenomena, but there's something about the relationship that someone has with those experiences as well, and our own conditioned understandings about the experiences that we have. So I'll stop talking now.
I'm going to have to leave you all, unfortunately. I'm going to get in the car and go and get my son, which means I won't be coming back on the show, but I'm going to try and listen when I'm in the car, if I can. I just want to leave you with a couple of tiny bits of information regarding my hypothesis about Mark and so on, so you can maybe think about that. I believe that Mark always had a seizure condition. I believe he always had one from birth now. And I believe that those seizures were so tiny that no one thought they were seizures or spotted anything. They thought he was deaf, for example, and they would think he was this and think he was that, or not paying attention, or learning disorder. But I think the seizures were like absences, and they would stop him from hearing or attending what's happening for critical moments when people are communicating with him. And he would then come back into the reality, and whatever they were saying had gone, and he was being expected to do something that he didn't understand. And I think that that's gone on in his life in his early years. And it would look like autism then, because he sometimes pays attention, sometimes he doesn't. Then he disappears into his own world. And his own world wasn't these absences. It was when he chose to not listen anymore because it was hurting him to come out of this absence and then be expected to know something that others knew and he didn't, like they're playing tricks on him. And I think that's what happened to him. And I think that's possibly what many people with autism have, that it creates this problem with learning because you're not attending to everything that's said. So you miss key points in learning. And then perhaps, I think in his case, he chose not to bother anymore because it was too much like being bullied. It was being played on him. You follow me? And so when he was stressed later in life, seriously stressed, people around him, he would then, his small seizure condition would turn into a massive explosion in his head, and he would have major tonic-clonic seizures. And so instead of treating the thing that I think was the cause of his problems, we treated something which was labeled and was in a book and that was the wrong thing to do. We've rescued him from that, but unfortunately now it's too late for him to have his life again. And he thinks like a 15-year-old when it comes to girls. But unfortunately, there are no opportunities. But I'll leave it like that because I must go and get him now. I'll try and stay connected on the phone.
Thank you very much, Ed.
Thank you. Thank you. Nice
and
to
I
meet
know
you both.
with your
Thank
time,
you.
but thank you very much on that. And we'll continue discussing some of the themes you brought up. So if you can continue listening in, that
I'll
would be
listen
really
later
great.
on. I'll listen to the
recording. Okay, that's wonderful.
Thanks, everybody.
Okay, thanks, Ed. Thank you. Thanks. Bye.
Thanks, Ed.
Natalie, what are your thoughts on all that in terms of what we've discussed so far?
My thoughts on both what you've each been saying is that when I made the study with the Alistair Hardy archive, looking into experiences, the issues were always, what was the reaction of the observer, the person nearby, the parent? How did they react to those experiences? And that depended on how it was interpreted on the whole. And it seemed that the experiences that people assumed were psychiatric were always those which were negative in the eyes of the beholder or of those observing or those present. And it's that kind of negative assumptions of the observer that I feel we need to tackle now.
Because that's an intriguing point, isn't it? That very much it is a duality, isn't it? It's a feedback situation whereby there's the observer and the observed, and people interpret depending upon their own social sets up and their own language and everything else as well. Because I was quite interested here discussing about Ed's son, and also the work that Donna is doing, because one of the people that have been a previous guest on this show, who is somebody I really am keen to get back on the show again, is Dr. Diane Hennessy Powell. And I don't know if either of you have come across Diane's work at all. This is very intriguing, and it probably is of interest to both of you. Diane, I heard about Diane indirectly when another of my guests many years ago was Daryl Trefford. And Daryl Trefford was the technical advisor for the movie Rain Man. And he was the guy that worked very, very closely with Kim Peek. And he was the guy that wrote the books on Kim Peek and everything else as well. And he wrote a fascinating book on savant syndrome many, many years ago. Now, he was then approached by a lady in India. And this lady in India was a mathematician. And she was observing in her daughter savant skills, mathematical savant skills. And whenever she asked her daughter to do a particular calculation, the daughter would always get it right. So she was convinced that her daughter was a genius. Daryl Trefford arranged for this young Indian girl to come over to the United States. And while he was witnessing her, he referred her to Diane Hennessy Powell, who's somebody that works with savant syndrome and various other things. And Diane set up a set of circumstances whereby this child was monitored. Now, the child was nonverbal, so it's quite important to note that she used a keyboard and she communicated with a keyboard. And they had a graduate mathematics student working with her, asking her the questions. So the student would ask a question and the child would give the answer, the mathematical answer. They then tested it and they realized she wasn't picking up verbal cues from her mother because they took her mother out of the scenario. But there was one peculiar set of circumstances whereby the mother, the student, was bored with asking the questions, as you would do after a time. And in her mind, the student started thinking, what would the answer to that be in binary code? So what she did was, she did the thought in her head and she said, oh, that would be 011011 or whatever. And as she did so, the child typed on the keyboard 011011. And she thought, she's not a mathematical savant. She's reading my mind. And then what she did was, and this is extraordinary, she then thought in her mind, if you are reading my mind, type I love you in German. And the child typed Ich liebe dich. And they realized that this child was in fact telepathic. And since then, Diana's been doing a series of experiments with telepathic children. And she's getting phenomenal results. I mean, I spoke to her about 2 or 3 years ago. Since then, she's been on opera and everything else as well. And I'd be really keen if maybe we could invite her here on this show to discuss her latest findings. So I think the dynamic with you two would be very, very intriguing, because it seems that we misdiagnose what's taking place here, isn't it? You know, it's a misdiagnosis. And I know that, Natalie, you're particularly interested in negative experiences. So Donna, in terms of that, do you have any of those kind of examples of your what do we call them, subjects, I suppose, in terms of negative experiences they've had?
I prefer to think of them as core researchers. And that's the idea of participatory research. It's trying to collapse almost those distinctions between the knowledge.
Wonderful. I do love that idea. I'd love that. Okay, please go on.
And that's trying to work its way into the ontological considerations. And that's about, you know, bringing in, this is the interdisciplinary, and I know in your paper, Natalie, which was a wonderful paper, I loved it so much. And I think you talked about the importance for interdisciplinary work. So some of this, and this is why we've got some great advisors around this study, is about bringing in, you know, the new scholarship around philosophy, you know, such as Bernardo Kastrup's work, objective idealism, and looking at a different narrative from how to understand these experiences from. Because if we start to understand a human being as an alter, for example, as a localization of consciousness, then is telepathy so illogical? Well, no, it's not, because we all have a porous qualitative field. That's what we are. So a bit like sort of things can come in and out. So it's about kind of reconciling that. I've completely lost my point, haven't I? I've gone off on a big tangent.
We were talking about extraordinary negative experiences.
Yeah. And was it about telepathy? He was talking about telepathy. Yeah, in the study, yes, children and young people reported telepathy, reported that they could.
Natalie was wanting to make a point there, yeah?
I wanted to make a point because I'm not looking at negative experiences. I'm looking at researchers and scholars who study the positive experiences, super clairvoyance, out-of-body experiences, beyond death experiences, near-death experiences. I'm looking at those researchers and scholars who study those kinds of experiences and assume that anyone who has negative experiences has a mental health problem. And I feel I really would like it if we could address that they're all human beings and they're having different kinds of experiences. And the researchers in established places, in corporate universities and research establishments, are creating the polarities by only studying benign experiences and excluding anyone who has negative experiences. Hello, there's a kitty on the scene. So that is my frustration, that we're not dealing with everybody as a human being or a self, but our esteemed researchers are only at their they've got a protocol to dismiss people who have negative experiences, and the protocol says let's remove them from the study. And so that's when I get really frustrated.
I mean, it was one of the things I mentioned in our last discussion, the way in which in my research and readings, particularly of the history of psychiatry, that you come across certain things and you think that's not the right way of doing it. And I was reminded, and I think I mentioned it last time, of an example that Bleuler used when he was in the Burgerholz in Zurich. the man who effectively came up with the initial term of dementia praecox and then turned around and called it schizophrenia. And he was describing a scenario where a young schizophrenic or person experiencing schizophrenia is the term I always try to use rather than schizophrenic, because that's a label in exactly the same way that we need to move away from. And this young guy was sitting in his cell with witnesses, and he turned around and he said, he's coming down the corridor. And suddenly somebody started walking down the corridor outside the cell. Then he turned around and he said, oh, he's mopping the walls. And then the guy was mopping the walls. And then he said, oh, he's dropped the mop. And a split second later, the mop fell on the floor. Now, this is one of the things that Ed and I have discussed over the years, because Mark seemed to show this ability. And Ed and I had discussed many times in terms of are people who have experienced schizophrenia, their time is off. And Ed once said to me, and he said, I sometimes feel that sometimes Mark is in the future, then he's in the past, then he's in his recent past, and he dips around and he's confused as to where his location is. And then I'm reminded of the work, and I know both of you are probably aware, and I know that Natalie has quoted this organization, the Hearing Voices Network. And I spent some time with the Hearing Voices Network in Manchester, and I spoke to a number of individuals involved there. And all of them said to me that under certain circumstances, the voices that speak to them seem to be precognitive. Some of them are benign, and some of them are not benign. But it's still part of the same phenomenon. And indeed, most interpretations when somebody hears voices, they tend to be of a negative nature. And because they're negative, they are defined as being schizophrenia or whatever. But when they're positive voices, they're defined as being divine. You know, they are communications from the spirit world that are positive. And yet, as Natalie said, you know, they're all a continuum. They're all part of the same phenomenon. And to just categorize them in certain ways is not the way forward. We need to be all encompassing in these things. And again, you know, your point, Donna, about the work of Bernardo Kastrup, you know, and I'm very much a huge supporter of Kastrup's work. I think he's an extraordinary writer. And again, the idea that we're moving more to an idealistic viewpoint of what nature is, you know, that consciousness is a field by which we attune into, in which case then telepathy and altered states of consciousness, out-of-body experiences, lucid dreaming, they're all elements of the same thing. And we need to be more working together on this. And that's why I really want to make this particular platform an area where we can discuss these in greater detail. Sorry, I grabbed the mic there a little bit too much, but I just really wanted to make those points. Natalie, have you worked with the Hearing Voices Network?
I haven't worked with the Hearing Voices Network because I feel it's subsumed by what we're doing. But I'm very interested in psychiatrists and psychologists who accept our point of view. And there was a psychiatrist, I can give you the details shortly, who published in the British Medical Journal because he had a woman who was hearing voices in her head who told her to get a brain scan. And apparently the people who did brain scans said, no, she's psychotic. We won't listen to her. But the voices were insistent, and they told her the address where she should go to get help. And in the end, the psychiatrist forced it and asked the organisations to give her a brain scan, and she was found to need immediate treatment for a brain tumour. And he has written this up in the British Medical Journal. Funnily
enough, I cite that particular case in my book, The Daemon, A Guide to Your Extraordinary Secret Self, because I thought it was so extraordinary.
Yeah. And I think I would like to see the psychiatrists and the psychologists on message with us, because I think there are, and I'd like to be able to work with them to create change.
There are two psychiatrist friends of mine that I think would be particularly interested. One is Mahendra Pereira, Dr. Pereira is somebody I wrote a book, I edited a book on near-death experiences with him. And he's a really interesting guy. And again, he pushes the envelope. And there is also a local psychiatrist I've worked with over the years, because one of the things many years ago, Mahendra Pereira studied under Alec Jenner, who was professor of psychiatry at the University of Leeds. And many years ago, Mahendra suggested I ring Alec. He was quite elderly at the time. He was an emeritus professor at the time. And I had a wonderful conversation with Alec. And he is recognized, or was recognized, as being one of the world's leading experts on schizophrenia and schizophrenia effects. And I asked him, and I said, what exactly is schizophrenia? And he said, we've no idea. He said, I've spent my whole life studying the subject. And all I know is that we're very good at defining things. I find it extraordinary that, sort of unusual psychiatric states are defined and placed in a book in America, and they're all given a code, and then everybody ticks down the list and says, these are the symptoms of this. But this is not like neurology. It's not as if it's based upon any empirical research. It's based upon interpretations. Natalie, you're going to make a point.
But can I make the point that there are people who have accepted the diagnosis of schizophrenia, and in order to work within the welfare system in the UK, they need to have the label to attract housing and support, and they do accept the label. So it's complex.
But they accept the label because there's almost no choice in that, in a way. Ed said something really interesting about there was almost a relief when his child was given a label, and I think that's really common in a lot of parents as well, because it is very overwhelming. It's very, very overwhelming for a parent. Especially if that parent doesn't have access to bigger narratives, around these things. So, it's that really entangled relationship between our social structures and, and what we feel we have to do, and what we do have to do, and what we do have to buy into, really, in order to have our other needs met. And I think you're right, Natalie. It's really complex. So, and again, that's why it has to be extremely interdisciplinary endeavour. Everyone needs to be involved from all disciplines. And I'm really sorry, Anthony and Natalie, I have to go now. I have to do a school run.
It's all right. I think we've had a wonderful hour's discussion, and I think that we've touched upon so many different areas that I'm hoping that the people that are listening in here or watching this, it'll be stimulating ideas in themselves, because this is the point I'm trying to do here. We don't have answers. We have people who have extraordinary experiences, and we're looking for a way of interpreting and understanding. And as time goes on, we're getting more sophisticated at understanding these things, but we need to not diagnose them too quickly. We need to understand them. What do we mean by autism? When we use the term autism, what do we mean? In my book, The Doors of Perception, I have a whole section on autism. I worked at Young Epilepsy for a time down the road from here, which is a school for children who have epilepsy, but also autism. And regularly, the individuals there that ran the houses there, we had about 250 kids there. And the psychic phenomena that took place at that location, everybody knew about it. Everybody knew the kids were psychic. The kids knew things that the trainee people didn't know. The psychiatrists didn't fully understand, but it's always the case that these people witness these things, but they know that because of academic tenure, they can't possibly ever discuss them outside of what they're allowed to discuss. And I know Natalie and I were discussing this recently as well. It's an important point. So again, thank you both for your involvement. What we'll do is we'll see if I can invite next time, maybe in the next few weeks, and see if we can get Diane Hennessy-Powell to join us, because if that would be quite a coup. She's a lovely lady, and I think that between the four of us, we can have an absolutely fascinating discussion on that. So please, by all means, leave that with me, and I can see if I can facilitate that. And as always, thank you for being involved in this. I know that your time is precious, and it's just wonderful that you're willing to take time out to get involved in the things that we're talking about. Just very quickly, Donna, if anybody wants to contact you, can you let them know either here or if you can post on on Facebook underneath exactly what your contact details are?
Yes, I'll definitely post.
Okay, and the same with you, Natalie, as well. Okay, guys, thank you very much for your time.
Thank you for inviting me.
It's all right, wonderful. Thank you. Bye-bye.